Yes.
Yes. Perfect.
I've started it.
Perfect. Thank you. So Digital Switzerland is an association and a foundation. And our vision is to transform Switzerland into a leading digital nation. Our mission is to coordinate and facilitate the process of digital transformation of Switzerland and to help Switzerland become a leading and fertile breeding ground for digital innovation. We are member-based with over 200 members and partners, which collaborate with us on different Swiss-wide initiatives in different areas, such as in education, cybersecurity, e-sustainability, and digital health, to just name a few. The aim of the digital health program is to digitalize the entire Swiss healthcare system and to make it patient-centric. One of the projects within the digital health program is the Swiss patient journey ecosystem map. And this map illustrates all the different digital solutions in Switzerland that focus on the patient journey and healthcare system. This map helps to better understand the complexity of the ecosystem, and its goal is to help find synergies between different organizations and to enhance collaboration as well as identifying existing gaps. We update this map regularly. Next update is planned for the end of the year. And we've created different categories for this map, such as health monitoring, healthcare interactions, medical data history, prevention awareness, and data interoperability. So today we have the chance of welcoming 3 players from the data interoperability category of this ecosystem map to our panel. So before we present the panelists and start with the discussion, we would be interested in knowing more about you, the audience, and the sector or industry that you are currently working in. So we have here set up a QR code for Mentimeter that you can just quickly tell us which industry you work in, so we have a bit of an overview. Who is interested in data interoperability? Quickly just...
Maybe, Cecile, if you leave the QR code, it might
sure. Yes,
simplify
sorry.
just for people.
Yeah. So, is it working?
Yes, it is. I think that we have the wrong question.
Yeah, that's
we have the second question. Yes, we have the second question, Cecile. Maybe just go one question before.
Okay. It should be the first question now.
Yes, it's fine now. Thank
you,
Cecile.
It's fine now. Perfect. Thank you.
Oh, is goed.
So here we see the results coming in. So we have very, very different industries joining us today. We see some public health, pharma, healthcare, but we also have people from education, sustainability, academia, consulting generally. All right. Thank you. This is medtech, I see. Yeah, this is helpful for us to really kind of get a picture of yeah, how many we were thinking most people will be joining from healthcare, so it's quite nice to also see that we have a very diverse group today. Okay. All right. Sorry about that. Let me just quickly here. Do you see my screen, the Meet the Panelists?
No, not yet.
No, we see you in this moment.
Okay, perfect. So here we are. So with us today, we have Serge Bignens. He is the president of MIDATA and head of Institute for Medical Informatics at the University of Applied Sciences. MIDATA Cooperative is specialized on health data management and has established a governance model and IT platform solution for citizen-centered and patient-centered health data aggregation. Our second panelist is Oksana Bober. She's the co-founder and CEO of iCure. iCure offers software as a service back-end building blocks for medical records and patient data. iCure, therefore, is specialized in medical data management for electronic health records and medical services. And last but not least, Gilles Lunzenfichter, the CEO of Medisanté. And Medisanté delivers medical IoT data as a service by abstracting in one cloud a broad range of multiple devices that require no configuration by the patients at home. You will hear more about the companies and the solutions they provide during the panel, but just as an overview, who we have with us today. Thank you for the time. So to delve into this panel, I'd like to know how the panelists define data interoperability in a few sentences. Maybe we can start with Serge. How would you define data interoperability?
I would define it as a capability to be able to reuse the data for different purposes, and also to move it from one platform to the other. So reuse within one platform over the time, because it's semantic, standardized, and be able to exchange it with other platform. We have actually multiple ecosystems, and they should also be able to be connected with interoperable syntax and semantic.
Thank you. Oksana, how would you define data interoperability? Do you agree with the definition from Serge, or?
Of course, because he's the head of medical informatics. I think that's exactly what I would expect from the technical side. But I would like to make one step back and say that actually I believe that medical data interoperability is a community effort. So, and the technology is only the lowest layer, which is the base of it. And I would estimate the effort, community effort required for that would be only accounting for 10-20% out of the total, because the second layer is actually all the regulatory and risk management, which is outside of the field of the influence of technology. And above all that, it's also the adoption and change management in the organizations which are supposed to use this interoperability. So it's really an effort, it's a joint effort, interoperability. That's how I see it.
Thank you. Joint effort. Maybe Gilles, although you are more also working on device interoperability, it still has to do, of course, with data interoperability. So do you want to add anything to this definition from Serge and Oksana?
Yeah, I think interoperability can be either very painful, or there is also an aspiration where there are some adjectives attached to it, that it would be seamless, that it would be secure, that it would scale. Basically, that the data would flow like a river from where it is to where it should be. So I think I will keep in mind the aspiration, because I think that's what we want for Switzerland and for the healthcare systems in general. And then I would just mention in our specific case about device interoperability, that I created Medisanté as a company because they had the vision that the day telemedicine will be a reality. I saw a vision where a patient at home takes blood pressure, and 10 seconds later, it's on the screen of the doctor. So for me, device interoperability is the day this will be a reality, whatever software the doctor is using.
Mm-hmm. Great, thank you so much. And also for the joint effort to define data interoperability. I also thought it was good to hear, Oksana, what you said, that it is a community effort and it's a joint effort. So before we talk about your solutions, it would be great to hear what the main hurdles are to data interoperability, specifically for healthcare, but maybe also more broadly, as we have an audience that is not just in healthcare. So maybe to Oksana, what are your thoughts on why data interoperability in healthcare is so complex, and what are the hurdles exactly?
I will start from my perspective, because we are working with so we are serving the healthcare innovators. So the customers of iCure, the small companies, startups, or projects which bring the innovation to healthcare. And what I see that the lack of that's why I can speak from that perspective, not from the perspective of interoperating with eHealth Swiss, for example, even that we are working on that as well. But what I see with the smaller with the innovators, and I'm happy that we have this community talk now, because I believe part of the people in the audience are in healthcare innovation, that the level of expertise on data management interoperability varies depending on the innovators, because innovators are normally researchers or doctors who want to bring their own solution to the market. And when I see they want to say, they imagine there is a magic button, which Gilles managed to create in Medisanté. When you press the magic button and the data is immediately in another system. But unfortunately, for 95% of these innovators, this doesn't work like that. And even if they want to connect with the hospital systems, it takes years to be able to send or receive the data. So I think this is here, and I would like now actually to readdress this also, like the continuation of the question to Serge, because he would see it from the perspective of the medical informatics and the more the research community, probably working with the hospitals. How can we simplify this connection of the innovators with the hospital systems?
Well, thank you for your question, but I would surprise you and maybe the audience by being a bit provocative and simplifying to the extreme. Gilles told us about the river of data that flows from A to B. With interoperability, A has the cost to make data interoperable, and B has the benefit. And we have an incentive system in Switzerland that A and B are silos with different business model or revenue model, and there aren't too many incentives for integrated care or communities. So we see that in particular in our national electronic patient record. The one that should publish the data in an interoperable manner have the cost, and the benefit would be for the other person downstream. And that makes it very difficult for startups to do it right, to do it for the community, having the investment. And the return on investment is for the whole system and not for the one that makes that effort of not doing proprietary system or so. So for me, it's we have to find a way how the effort of the one that are pioneer gets rewarded.
Mm-hmm.
And that is difficult in the healthcare system, in the what is based on from our health insurance, which still has a model in silos, and that is a hurdle. And as Oksana said at the beginning, the technology is the easy part. It's to build that community with not so good incentives at the model. It needs new thinking of business model and partnership.
This, thank you very much. Maybe also Gilles, before talking about solutions, because it does sound very, your solutions are one of the aspects. It won't be a solution to all the hurdles for data interoperability, but maybe Gilles, what is your take on what's the main hurdle that it's so hard to reach data interoperability in healthcare?
Yeah, so I heard several times the word silo, and so there are always good reasons why there are silos, and interoperability, it's about breaking the silos. So in my world, which is about device interoperability in virtual care, the obstacles is that there are silos on both sides of the river, right? As I said, we're a kind of bridge between the highly fragmented and siloed medtech world and a highly siloed health IT world. And what is also a big hurdle is when hardware companies start to write software. The only way they can do it is to do it in silo, because you know, hardware is by definition a silo. So basically in medtech, it means that every manufacturer of every device adds a little mobile app, a little proprietary device cloud, and a little pool API. And that's where the nightmare starts, because there are like 50 or 100 significant medtech vendors that play a role in the home. And so I would say that every piece of software for hardware vendor is an obstacle on data interoperability. So we looked at that. And maybe the second point I would like to make is that usually device in terms of interoperability is mainly an IT topic. So the guys who fix interoperability issues with their screwdrivers or IT guys, right? But in fact, there are multiple stakeholders involved in those processes around IT. And so in the case of device interoperability in virtual care, it's all about the device interoperability is just a piece of the device experience. You also have the device connectivity for the patient. You have the device assignment for the doctor. You have the device management for the biomedical engineer. You have the device ordering or the device logistics for finance guys. So the point is, you cannot fix the world by just fixing interoperability. You need to have all the colleagues of the IT guys who desperately try to fix interoperability, who pull the same string with a common goal. And this requires a vision, an overall vision that is beyond the technical vision of data interoperability. And sometimes aligning all the bits around the common vision with multiple dimensions is a pretty big challenge.
Mm-hmm. So you're talking about the vision. Maybe this leads us to more solutions. Maybe before we talk about your specific solutions, one of the visions, or what is always talked about, is the aspect of standardizing. How do you feel about the standardizing? Why aren't we further than we could be in that respect? Is that also a hurdle in your view? Gilles.
Yeah, so I'm totally passionate about standardizing. As there are many people from IT, so on the team here, I think everybody is familiar with what happened to the IT industry over the last 20 years. It basically started with one element of standardization, which was the introduction of an Intel chip, Intel inside of servers from HP, Dell, IBM, etc. And this is the beginning of a commoditization of the hardware by being able to abstract and manage it in the cloud and then deliver IT as a service. So I believe very much in standardization whenever it's possible. And I believe in medtech, it will be similar. You know, there will be a standardization of home medtech vendors, because it will be possible to abstract them as an IoT module or an IoT SIM card with the housing around, you know, this SIM card. And once you abstract in the cloud the hardware, then you can manage it across vendor silos. And then you can deliver IoT as a service, which we really try to do to the care teams, that they have the data in 3 minutes instead of 3 months when they see the patient in person. So yes, standardization, every industry needs to find a way to have at least the beginning of a standardization. And so our approach is to start with the telecom aspect around the device to transmit the data.
Yeah. Maybe Serge, could you tell us about your MIDATA, your company solution, and maybe also how you try to tackle this standardization issue, if that's relevant?
Thank you. I would add to what Gilles has said that you need the standardization, you need the API, and then you need that the people on the two sides of the API agree to exchange data and come to a win-win situation. And that's the difficult part. And MIDATA positions itself as a data intermediary. We're also involved in Horizon Europe project where we have this position. And then the data intermediary has to move in an ecosystem. And in most of our project, we try to have in the project consortium, the different party, the one creating the data, the one that are processing it, the one that are sharing, the one that gets the benefit, and have a common goal and a financial distribution that all get something out of it. And then the standardization, the technical standardization is an easy part because you build the ecosystem. So MIDATA is a platform, but for each project, we built a consortium where MIDATA is part of it. And we have on a peer level, hospital, authorities, patient association, third-party IT companies, and we build the use case. That takes a bit of time, and the use case makes it all, because then you know what data you transport, you look what are the standards, and then that flows. So that is our positioning to be a data platform with a data governance, which is already described, because that's the other difficult part. But the data governance, we have it in the article of association, so that is solved. So we worked on the use case, and lately we're able to put a use case that leads to a consortium, to a project within 2-3 months, and then we have a case that we then need a couple of more months to configure, implement, and we are live. So that's the way we solve this challenge of having a community which is difficult to do at the national level about everything. So we try to identify a use case and build that consortium where we discuss about the incentives so that there is a win-win. And only when we have that, we start the project, not before.
Your company is also very focused on patient centricity and wants the patients and citizens to really give granular consent to data use. Could you maybe explain how maybe that looks within your platform?
I will start with the governance. The governance is that the owner of the data, whatever project that is, whoever are the actors, is the account holder, the patient, the user. MIDATA doesn't even access to it because the data is encrypted and there are some technology about encryption and so. And then we say to a group of people, if you agree with that, we'll put up a project. And I will take an example. The last one we started is for a national initiatives to allow patients to collect the state of their health, called patient-reported outcome measures, PROMs. Some of you may have heard that. And we say, well, whatever hospital, rehab clinic, whatever institution that wants to do quality assessment, the iCure or the Federal Commission for Quality or a specific clinic that agrees to that rules can come to the community. And there is no discussion about, out of all these actors, who's really the owner and who can have access. We say it's the patient that is the rule, no exception.
Mm-hmm.
And that doesn't apply for all the cases. That is difficult, but that is a DNA that cannot be discussed because it's the article of association. And then we have that strong positioning, and that allows afterwards the different stakeholder to agree on the processes, because that is solved. It has been approved by so many data protection officer. It is legally defined. We have all the templates about consent management, about approval. We can go to ethics commission if it's for human research, research on human, and so on. So we have this hard work done. And then we concentrate on the difficult part of having all the stakeholder in a win-win-win-win position.
Thank you, Serge. Maybe Oksana, can you tell us what your company's solution is? As I understand it, you have a lot of similarities with MIDATA, and maybe also how you try to connect your solution to the entire health ecosystem in Switzerland.
Yes, thanks. I would actually wanted to follow up a few phrases on standardization, because in my opinion, we have already enough standards which have been being developed for the last 20 years. All the data models which exist out there, HL7 is 30 years old, all the IHE profiles which allow to exchange, and it's a non-for-profit, non-governmental, and actually non-national organizations of scientists, researchers, and implementators who work on that. And I even see in the audience some people who are involved into this interoperability from specifically from this execution standpoint. What I see on one hand, that on standardization, we have enough standards, but somehow each project creates a customization of that standard, which actually makes the standard quite difficult to work with the same standard somewhere else. And let's take something like HL7 FHIR data model. I'm sure most of you know very well, and then we have different localizations. And from the other side, when I'm thinking about how it's set up in healthcare and industry, I'm talking about the hospital. I have seen multiple hospitals in Switzerland and in Europe where a hospital will have several EHR systems, each serving separate department. Even here in Canton of Vaud, one of the hospitals said that they had one EHR which was acquired by the hospital, but on one separate unit understood that doesn't work for them, that they wanted to have their own. So, and if you can imagine, those two systems, they don't interoperate. So it was an effort for a project for several years to make them talk to each other, these two EHRs. From our hand, I know that we would not be in a position as a small company to come and revamp everything. Like if I would I would have a magic wand to do that. I would not be that possible. So where we bring our contribution and our effort is by serving, as I mentioned, the innovators who start developing new solutions, or actually do the transition from something which is that they want to actually to change for the more innovative. So what we provide as a solution, we give the toolkit, which is the entire engine. Like you imagine in any car, you would have the outer of the car, and then you would have the engine which runs it. And normally the car builder is not building the engine from scratch. They normally already use the engine which often even had been built by the party. So we are the company, iCure, which gives that engine to collect, process, and exchange data to those innovators, together with all the toolkit, actually how to connect that engine to their individual solution. For example, if we would have the outpatient monitoring, and I'm talking, I would call it, okay, we're quite similar to what Gilles is doing is Medisanté, but our more serving companies which are on a software as medical device and electronic health record, not going into the hardware integration of connectivity. So, but we give a very similar way how I explained with the engine. We give the full package of the engine, which already protects their data. We do not have access to the data the same way like MIDATA has. So we do not touch it because we actually do not have even the keys to have access to that. But at the same time, we work as the enabler for their innovation, because in that case, they can focus on where is their area of expertise, rather than starting to build their own data management engine themselves. So they receive it from us, they integrate with their own expertise, and then they are much faster in the market. And where we see our mission with the interoperability specifically, that by default, what we went through as a technology, from the technology side, we prepared it to be interoperable according to those most common standards that I mentioned in the beginning. The IHE profiles to exchange the data at the global level, and also the data models. And then depending on the customer needs, they either decide to integrate it at once or not. But what we provide is there. So with this help, actually, we give them at much lower risks, much higher quality data management expertise that they would require internally. So that's how I'm connecting the standards and actually what we do to bring in the standards even to the companies who would not have otherwise their internal resource to do it themselves.
Mm-hmm. Thank you, Oksana. It's interesting that you also mentioned that you compared yourself to Medisanté, and that the fact that you don't do the hardware stuff. Maybe to give Gilles the opportunity to quickly explain what you do at Medisanté. You also explained a bit before already, but maybe shortly, what do you do and what solution do you have for device interoperability?
Yeah, so basically we have created a global cloud bridge between two highly regulated industries, home medtech on the one hand. We, for instance, have a partnership with Boehrer, which is the biggest home medtech vendor in Europe. And the other side of the bridge, let's say, or the river, to stick to my analogy of the beginning, is the health IT system providers. And I see on this call, there are some representatives of health IT system providers. I say hello to Stefano from Daedalus, but I believe there are other ones. So we have created a cloud bridge between these two worlds in a specific use case, which is hospital at home, virtual care, remote patient monitoring. And yeah, this is, I think what matters in the next pandemic in this context is that as it's about having data flow across silos, in fact, if IoT, the Internet of Things, this device interoperability, in fact, it can make the healthcare system more data-driven if the data flows from the device to the health IT systems. And in a pandemic, a healthcare system, a national system that is data-driven and can collect data from devices at home from elderly patients between 75 and 90 were the only people that had to be protected during the last pandemic. You know, these were the most exposed, the most fragile ones. Well, if this IoT data collection can be seamless and secure at scale, then the healthcare system will be more resilient. And that's why gives me energy when I wake up, that it's we try to apply global technologies for non-identifiable data for the good. Yeah, I hope that in Switzerland we'll be able to contribute as well in the future more than we do today.
Thank you, Gilles. This actually leads me to the last question to you panelists before we open for the Q&A. You, Gilles, actually already explained a bit what your vision is for a healthcare system 2050, if I understood correctly, to have a remote health monitoring system overall. But maybe in 2 or 3 sentences, explain to me what would your perfect vision be for the healthcare system of 2030?
Yeah, so maybe 2 or 3 points. First of all, I believe that the hospital of the future is the hospital at home. It's inevitable due to resource scarcity of medical staff. In the past, we could take the Russians who went to Ukraine, who went to Poland, and the Poles went to Germany, and the Germans went to Switzerland. Now the supply chain has been broken, so we need to think of how to utilize technologies to cope with the scarcity of medical resources. The second thing is remote patient monitoring. In this context of hospital at home, there needs to be public funding, and there are 2 ways to enable IoT data collection and remote patient monitoring to scale in the next pandemic. It's either you do a public tender, like happened a few weeks ago in Italy, and you say, hey guys, for 250 million, you know, we enable telemedicine. One piece of it is remote patient monitoring, and sub piece of it is IoT. And then you do a second tender with the EU resiliency funds. You say, and by the way, now we do a tender for 500 million for devices. Okay, then, you know, you can probably enable the hospital at home with cloud technologies and IoT technologies. The second option to put public money into to enable this vision of hospital at home and remote patient monitoring is what the US has done in 2019, what Germany started to do in 2022. And what France starts to do now in 2023, it's to put money on the table so that doctors get paid. So it's basically a reimbursement of remote patient monitoring. So basically this means that a doctor who is in charge of remote patient monitoring will earn $1,300 in the US if he does it, 1,300 euro in Germany if he does it, or 1,300 euro in France if he does it. And hopefully someday, if Tardoc is not too tard, then maybe with Tardoc, it will be a Swiss doctor will earn 1,300 Swiss francs to do remote patient monitoring for let's say 50,000 patients who suffer from hypertension and represent probably a huge cost. These chronic conditions represent 80% of the healthcare costs, right now. So addressing that instead of having digital officer of 35 health insurance, play around with some stupid mobile app here and there, it might be a better use of their time. So it's a call for action that they focus on real problems with the Ministry of Health in Switzerland.
Thank you, Gilles. Oksana, what is your vision for a healthcare system 2050?
Okay, so as I'm a big advocate for bringing innovation in healthcare to the patient faster than what we have now. And I think that this is where I really liked what Serge said in the beginning. And I think, Gilles, now what you repeated as well is actually the incentivization, which becomes the canvas of the system, which equally motivates the different stakeholders, not only one side. And I think the example which I could give, and Gilles, I appreciated your examples. The example I could give is linked actually to the interoperability, the one where we participated as the company. It's not in Switzerland, it's in Belgium. The example is that for the GPs, so for the doctors who share the data with the applications which they use to the e-health system of Belgium, they actually receive the incentive on their account. And it happens already now. It happens already for the last 7 years. This somehow we still don't have it here in Switzerland. And the same goes about any innovative product, because observing how much innovation happens when I participate and when I contribute to the accelerators or incubators, and I see how much research has been done. Switzerland is so rich in that research and innovation, and I truly believe that what I see in those technologies on the accelerated treatments, on treating the orphan diseases, on the faster drug recovery, that should arrive faster to the patients. Mm-hmm. And I think maybe doing the common effort as a community to create the proper incentivizing system, which will still be fully compliant and de-risking everything for the patient and also taking care of the costs, but that could help bring the innovation to the patients. Mm-hmm. And I hope we will arrive that in I hope faster than 2050, because really I would like to see it sooner than that.
Let's hope it's sooner than that. It's more to really have a real vision for what's to come in the next 25 years.
Yeah. Because just one small moment I forgot, because for us, interoperability and data, this is just the tool. Because the thing that we're talking about people, we're talking about us, our children, our grandchildren, and about the health, our health and prevention. So what we're talking about, the data and interoperability, and we work in this field, that's for us the tool to make that. So that's the vision for 2050.
Thank you, Oksana. To close off, Serge, what do you wish for the future of the healthcare system?
So I agree with Oksana and Gilles. I would say, in addition to that, a better financial recognition and incentives for care coordination. There are only pilots projects of health networks that emerge in Switzerland, but we don't know if they will be able to scale. So there is a need for recognition of coordination of care. And if that needs is recognized financially, then there are so many clever heads and innovators that will grab that market, and the market will ask for interoperability, and it will happen, and we are all ready. So there is this pool which is needed from the healthcare incentives model, or a push which is to say, like the US did, an API is mandatory on FHIR semantic on each EHR from each hospital. And then there is a data economy that develops on it, with the big players coming to that, and a combination of startups. So either financial incentives, or which I would prefer, or having API mandatory, and not, we have too many things which are optional and not mandatory. And I think the rest will happen, as Oksana and Gilles said.
Thank you so much for your visions. It's always also inspiring to hear about visions and actually working towards these visions. I'd like to open up the Q&A that Jade will now moderate. Feel free to really just ask your question in the chat, or of course also raise your hand or just turn on your camera and ask the questions.
Perfect. So thank you so much, all three of you, for your great insights, and for Cecile for this really insightful and motivative moderation. So we already have a few questions in the chat, so maybe we can start with these. And for others, just please raise your hand, and then I'll give you the floor as well to ask your question. So there was a first question from Joe Max Wakim, who is wondering, is there a national health data governance framework that facilitates the exchange and use of health information? I don't know who from the panelists wants to try to tackle this question. Yes, Serge?
There are pieces of it. The standardization, there is a large agreement about the framework that has been mentioned, either IHE or HL7 FHIR. There are some elements which are specified in the electronic patient record, and there are platforms that combine that for B2B services. So there are pieces of a national standard and platform, but it is neither mandatory nor there is a financing model for that. So everybody is ready in the starting blocks, but it doesn't happen.
Perfect, thank you.
I visited a few countries this spring. I had the chance to do a sabbatical, and I observed they are the one that do something mandatory. In Portugal, they have a patient summary. It's mandatory for all the establishment. It was through the help of the European Union, and they deployed it to everybody. And the US said the API is mandatory, and then things happen. So you have to have something that triggers, and we don't have that courage in the moment in Switzerland. But we have the pieces, but not the complete puzzle.
And I will add two more examples to the two more national frameworks. So it would be Belgium and Sweden. If you would look in detail how that is organized either in those two countries, that's exactly the model where the doctors, it's not okay, they will not be punished for not sharing the data, but actually they're incentivized for sharing the data. That's in Belgium. And in Sweden, it's the transparent sharing of the relevant data to the national system, and the same way through the API, the access to this data to other participants. So those systems exist.
I think that kind of leads well to other questions from the chat from Guido Riedweg, and also other people were mentioning about it. This whole idea of the flow of information, of the whole data, but at the end of the day, the owner of the data is the patient. So how can you ensure that the information that's being flowed and shared in different ways is well communicated to the patient? The patient knows where's their data being used, how is it flowing? Is there like specific standards that you would recommend, or how would you kind of envision this idea as we're talking a bit about the topic here? I don't know if one of you wants to start covering this topic.
Okay, I can actually, I would like to take that just to start answering that question. Yeah, of course, the owner of the data is the patient. So us, we are the owners of our own medical data. When we come to the doctor, we transfer our right, we give our consent to the doctor to use the data. And as the laws in the privacy law defines in Switzerland, and also the European Union, where we often exchange the data, is that the data has to be used for the specific purpose and with the authorization per that purpose. This is different in other countries, like the US. It has a different framework on the consent and the privacy of patient data. So it's not, we cannot compare, it's not apple to apple comparison, talking actually about the API and the data freely flowing, because I believe that in Europe and in Switzerland specifically, we have more protective laws for the individual privacy of the patient. And actually, I salute that. So I appreciate that we do have that. That is actually the individual data can be protected and would not be abused to a certain, like protected from abuse to a certain extent.
Perfect. Thank you very much, Oksana. I don't know, Gilles or Serge, if you want to add upon this, or if we should tackle the next question. All right. Otherwise, maybe Gilles, you want to express a bit, because we saw there was a question in the chat from Peter James around what does it take to make it happen? And I saw you were starting to answer. So maybe you want to share this to the rest of the audience here.
Yeah. So I've seen the difference between Europe and the US in how they foster the adoption of whatever topic, right? Let's say in our case, remote patient monitoring. So there are some countries, they do 15 years of pilot projects. There are others, they tell a doctor, oh, by the way, you earn $1,300 if you fix it. Guess what is most efficient? Because in the US, basically, they introduced remote patient monitoring. They say, hey, $1,300, yoo-hoo, yoo-hoo. Then the doctor say, how can I grab it? Then the guys talk to whoever, you know, whoever they find fixes the change from the device, the telecom, the remote patient monitoring platform, the billing, etc. And at the end, it's not perfect the first time, but ultimately it works. And maybe in Europe, there has been a lot of experimentation, but again, in silo, every country experiments, you know, so after 10, 15 or 3 years, every country comes to the same conclusion. But maybe Europe would have gone faster if they had adopted some of the pragmatism of the US method by showing first the money, because the money drives people. I thought it was emotions who drove the world, but in fact, money drives the adoption of interoperability in healthcare.
Perfect. Thank you, Gilles. I think, as you said, Switzerland sometimes is too much siloed and should open up in its horizons to what's working in other countries. We have one other question from Stefano Napolitano from Dedalus. He's wondering how much the uneven distribution between public and private health market is a roadblock for common centralized standardization in Switzerland. I don't know, maybe Serge, you want to try to answer this question?
Yes, there are fragmentation between public and private. There are fragmentation between ambulatory and stationary. And all those fragmentation make that when A has an advantage, B is losing, and it doesn't happen. So those fragmentation is where the US are strong. They create a market, as Gilles just mentioned, and people agree on that. And we rather divide things and regulate and split. And then it's very hard to bring the pieces back together. We could say there is a chance to have public and private because that gives innovation. There is an initiatives for integrated care in the Jura, Réseau de l'Arc, which is really very privately oriented. But we don't know if it will scale. And the public initiatives or electronic patient record is very administrative. So yes, we have those fragmentation, and it's only one of the fragmentation. There are many that adds upon each other.
Perfect. Thank you very much.
We have to break them. We have to break them.
Yeah, that's true. We have time for one last question if someone has one last question in the audience. Otherwise, we'll start slowly closing. All right. Well, thank you very much, all of you, for your time and interest in the topic, and especially to Oksana, Gilles, and Serge for explaining and sharing a lot of their insights. Oh, sorry, excuse me. Someone wanted to say something? Okay, no, I guess it's just some sound. So yes, thank you very much for all these learnings. What we can really come out of it is really this joint effort information. It's really, we need to discuss more together. And I think through these types of channels and other types of channels, really try to exchange together, because it's through a team spirit and this kind of ecosystem approach that we're going to be able to actually go to the next level in such topics. So it's, I think, quite important. And yes, for sure, we need some financial incentives, but I think this we will hopefully, let's see if this comes along from the Swiss government as well. But at least as a team of thought leaders in this space, we really need to support each other, enable each other to really be able to succeed in data interoperability. I think, Cecile, you had one last question that you wanted to gather from the cohort to with the Mentimeter, I think, to see what was your biggest learning from today. So this also helps us organizing next sessions. So if you can just take a second to fill this one out as well. And then, as mentioned in the beginning by Cecile, so these 3 players are part of our Swiss patient ecosystem map, and we are always trying to build it, bring the new players into it that are out there in Switzerland. So if you hear of any new players, if there's anyone that's missing still on the map that you believe should be there, please let us know, because this is actually quite relevant to a lot of stakeholders in the ecosystem to start learning about who's doing what outside of their own silo. But let's just get to the Mentimeter and see. Maybe, Cecile, you want to then show the learnings.
So here we have responses coming in. Financial incentives make change happen. The graphic representation of the ecosystem. Collaborative approach that was mentioned in the beginning from Oksana, but always mentioned again in the discussion. Just freaking do it.
I like that one.
I like that one. That there's a wide framework to use and act upon. It just takes consistency and to align with the existing standards. Too many silos in Switzerland. Perfect. Pain points of the interoperability setup currently and what it would take to break barriers. Thank you so much.
Thank you all, and we wish you then a lovely lunch if you haven't yet eaten, or a lovely afternoon, and thank you very much for spending this time with us. Special thanks again to the panelists and to Cecile, and we hope to see you soon in another of our events.
Thank you to the audience.
Thank you. Bye-bye.
Thank you so much.
Thank you.
Bye-bye.
Bye.
Bye.
Bye, everyone. Thanks.